COVID-19 was first documented on December 12, 2019, when a cluster of patients in Wuhan, Hubei Province, China, began to experience shortness of breath and fever. On January 20th, 2020, the CDC confirmed the first U.S. laboratory-confirmed case of COVID-19 in the U.S. from samples taken on January 18th in Washington state. As for Texas, we can document the first persons with COVID-19 in February 2020 as San Antonio's Lackland Air Force Base began housing people who had been overseas and exposed to the new coronavirus. News reports from San Antonio on February 25, 2020, cited CDC information stating that 6 persons with COVID-19 were at Lackland Air Force Base, including a traveler who had returned to the U.S. on a State Department chartered flight from Wuhan City, China, the epicenter of the outbreak, and 5 passengers from the Diamond Princess cruise ship quarantined in Japan. With this history in mind, medical personnel and first responders have been dealing with stress related to the pandemic for 2 years, even if their first direct exposure came after these initial dates. Equipment shortages, personal protective equipment shortages, death by suicide, stress that resulted in career changes, stress from repeated and long-term exposure to the suffering and mortality associated with this disease before and after vaccinations were available have contributed to this stress, anxiety, and other manifestations of mental health disorders. This section addresses leadership during COVID and the experience and impact found by our colleagues and ourselves and effective strategies to address these needs. Levin, writing pre-COVID-19 pandemic while researching the 2003 SARS pandemic, found that pandemics cause high stress, depression, anxiety, hostility, and somatic symptoms, that is, symptoms without discernible organic causes. He then writes, left unaddressed, emotional needs and wounds of healthcare personnel grappling with an outbreak can reverberate long, perhaps for many years, after an outbreak has abated. Pandemic survivors experience stigma that prevents care seeking, and bias associated with immigration status may also reduce care seeking. Healthcare workers, indeed any first responder, may confront emotional impacts, risk of infection and death, separation due to protective isolation or due to required extra shifts or increased duty cycles, witnessing disfigured or dying patients, working under surge conditions with limited protective equipment, medications, and long wait times, hopelessness due to massive losses despite best efforts, dealing with the bodies of the deceased, quarantine periods, fatigue, and burnout. Providing leadership, structure, and delineation of duties, as well as preventing stigmatization, loneliness, and isolation, were effective in confronting the results of these experiences. Some strategies to provide leadership include addressing staffing needs, establishing predictable schedules, and developing educational materials that address stressors from the public, patients, friends, and family, and other care providers. Additionally, support from supervisors and colleagues to address isolation and use of a buddy system help with isolation and preventing stigmatization. Caring for spiritual and psychosocial needs includes burnout prevention by providing relief from duties, limiting overtime, and incorporating relaxation, mindfulness, and resilience techniques. These techniques, such as deep breathing, progressive muscle relaxation, and guided imagery, once learned, can also be passed on to patients with beneficial outcomes. Morale and teamwork enhancement might include staff appreciation events, leaders verbally acknowledging contributions, and providing access to spiritual leaders, particularly those who are already integrated into the workspace, fire department and EMS chaplains, and hospital chaplains that are familiarized with a particular environment and the set of needs of a team. Dr. Bierman Fote outlines some brief and effective techniques to increase satisfaction amongst your colleagues. Frame your mindset. Start interactions by reminding yourself that folks in your organization want to achieve positive outcomes. Framing your outlook towards shared compassion and a desire for understanding allows you to recognize positive efforts in your colleagues. Express gratitude. Remember that just doing the job requires a decision to do it well and to participate. Recognize these contributions. A text or a handshake with a smile can go a long way. Make this a habit. Invest in their future. If you're in a position of supervising colleagues, as well as being a leader, express interest in your colleagues' goals and ambitions, and help them achieve them. Providing a pathway towards long-term success increases engagement and retention. Being a servant leader is important when addressing these needs. Empower employees. Allow frontline employees to resolve issues on their own. Help out if you are shoulder to shoulder, and if you're a supervisor, help only when absolutely required. Encourage the team to find the solution on their own. This builds esprit de corps. Of particular value during pandemics is supporting the ability of those on the front lines of care and service to care for their own families and loved ones. Some techniques that Levin reported in the psychiatry of pandemics including access to psychosocial programs for the families of workers as well as the workers themselves, lending electronic gear to workers to increase their ability to communicate, and participating in virtual spaces, providing continuing education about infection control measures to protect workers and techniques to protect their families. Finding a way to allow the community to show appreciation is helpful, and ensuring fair compensation are effective steps to support staff during pandemics. It's worth repeating and honors Maslow's hierarchy of needs that caring for the families of frontline employees allows them to focus attention on the job at hand when their most basic needs, such as the well-being of their families, are being addressed. As Maslow's hierarchy shows, breathing is important, but safety of the family comes right after that. Therefore, as we deal with the difficulties of the pandemic, ensuring that families can access psychiatric care, pharmacological treatments, and any psychotherapy required will help them deal with the mental health challenges associated with the pandemic. In summary, Dr. Kanak offers the following guidance to provide culturally competent care. Help others learn what to say and what to do. Use person-first language. Confront your own implicit biases. Increase social contact by inviting members of a marginalized group to share their experiences with your team. Confront prejudice with knowledge. Remember, prejudice is based on false beliefs. Highlight people who are willing to demonstrate their recovery and are realistic about periods of reoccurrence of substance use or periods of need for continuing care for mental health disorder. It is important to help first responders and healthcare workers understand that with treatment, people with substance use and mental health disorders do get better. Knowing measures to avoid stigma and reduce bias and prejudice will help our colleagues, patients, and those we serve reach out for, receive, and continue the treatment they need. So, teach skills that help healthcare providers know what to say and what to do. Model person-first behaviors. Make ample use of social contact, hearing first-person testimonies from people with lived experience of a mental illness who are trained to speak about their experiences of illness and recovery, as well as their experiences within the healthcare system. Myth-busting, or a transformative learning focus to target unconscious biases and correct false beliefs that may be negatively impacting care. Focusing on correcting false beliefs, improving language use, and increasing awareness and self-reflection. Demonstrating and emphasizing recovery from a mental illness and showing ways which healthcare providers play an impactful role in that process.